Here at Strategic Spaces, our goal is to provide you interior solutions within the six-sided box called Your Space. We developed the Spacemaker process that helps you bring your project from concept to completion.
What we would do is get to know what your needs are to help create a space that will be within their budget and your aesthetic.
Everything is customizable to what the client is looking for.
Using some of our software, we can virtually render a space for you.
The fourth step of our process is to implement these solutions into your space.
We like going in and molding what we do around what they need.
They have a good sense of the way that the marketplace is changing almost before everybody else does.
It allows us to really customize the fit, feel, and functionality as your company goes into the next phase of its development.
Hello, everyone, and thank you for joining us today for MassBio's April Town Hall on Innovation and Access in Mental Health Care. I am Chandra Ramanathan, Global Head, Pharma R&D Open Innovation at Bayer. I'm also a member of MassBio's Board of Directors. As I was preparing for the town hall, I came across these statistics that startled me even as a life science professional. 1 in 5 adults in the US report having mental illness in 2019, staggering 50 million people. Only half of them get the treatment. This real problem has only escalated during this pandemic. A recent CDC survey suggests 40% of adults, that's double the number, report having mental health issues. Not only it has escalated, it is disproportionately affecting younger Americans, around 75% in this survey. To help us unpack this issue and discuss innovation and access in mental health care, we are very lucky to have Dr. Kerry Ressler. Kerry is a Chief Scientific Officer, Chief of the Division of Depression and Anxiety Disorders at McLean Hospital. He is also Professor of Psychiatry at Harvard Medical School. Kerry, great to have you here. Thank you so much for taking time to meet with us.
Thank you so much, Chandra and MassBio, for sponsoring this today. It's a real honor to be here representing McLean in the field of psychiatry.
So, Kerry, like I mentioned statistics at a very macro level. I thought we could start with a micro issue here. What is going on at the McLean Hospital? How you have been addressing the mental health issues during COVID-19? In particular, how are you ensuring patients have access to right services?
Absolutely. It's obviously been a struggle for all businesses we know, all hospitals. At McLean, we're committed to providing resources to help patients and staff manage their mental health throughout the coronavirus pandemic, before, during, and after. And we were very fortunate to be able to very rapidly, in the first weeks after the pandemic started and the shutdowns began last spring, March really, to be able to go to essentially all virtual for our outpatient programs, our partial programs, and then to put in place protective measures, testing measures, rapid testing approaches, et cetera, to keep our full inpatient units and our residential programs active, so that we're still able to see upwards of 100,000 patients annually and continue the mission for mental health care, while continuing to also have a variety of COVID-specific offerings for the general public and our patients, from self-care, wellness, group support, on-demand webinars, skills training, et cetera, for really a full set of approaches. So at the end of the talk, we'll also provide some resources for anyone who may be interested for mental health support on the sort of range of slightly worried and anxious to really more severe struggles during this period.
100,000, amazing. And I want to thank you, Kerry, and all members of the McLean team for helping patients during this pandemic. So let's talk about some key challenges. So what are the key challenges in terms of unmet need and also enabling access in mental health care? And can you also elaborate on some of the recent major innovations?
Absolutely. So, most of the challenges that we've had obviously predate. There was a mental health care crisis in the country before COVID, and certainly COVID has only exacerbated some of those. So I'll break down maybe the challenges into sort of the systemic healthcare problems, challenges, and gaps, and then really biopharma pipeline and treatment gaps that we've had. So from a healthcare structure perspective, there's really been the ongoing issue between parity and healthcare reimbursement structures. While there was a lot of talk about parity a number of years ago, it never really hit in terms of financial parity for payment, reimbursement, et cetera. In fact, most psychiatry departments around the country operate in a deficit, and they're almost always supported by other aspects of the hospital. Fortunately, McLean, we've been able to overcome that, but it's a big problem for the field generally, is that the reimbursement rates are so low. So that's a structural problem. We also have a gap where most of the providers are, which is the big cities and where they need to be, which is distributed rural areas, underserved areas, et cetera, so that many patients who are in most need do not have trained experts within anywhere near them, or even hundreds of miles, depending on where they are. So those are some of the structural gaps that we've always had. And that have only been exacerbated by COVID. In terms of the treatment approaches, there's really been a gap between our diagnostic framework and the biology of our targets. Our diagnostic framework is broad. We have depressive disorders, anxiety disorders, psychotic disorders, substance abuse disorders. And yet the way the brain is wired and the way biology works is obviously much more subtle than this. And there are likely hundreds of different biological subtypes of depression or schizophrenia or even substance abuse. And only as we can start to have better targeted engagement of our new therapeutics and treatments towards the underlying subtypes of disorders will we have a much better pipeline for discovery. And on the same point, another gap is really the limited mechanisms of action of most of our current drugs, which are really all based on serendipity. And most of both our antidepressants and our antipsychotics and anti-anxiety medicines are all targeting broadly the monoamine systems of dopamine and serotonin and norepinephrine. And the very rich nature of targeted circuit biology has not really been understood yet. I mean, we're starting to understand it, but in a way that has been translated properly into new therapeutics. So that's where some of the gaps are. The innovations, though, are very exciting. One thing that COVID has really done is led to a really rapid transition to teletherapy, really nationwide and if not worldwide. That's overcome many of the regulatory barriers that have happened for years and have slowed down the process of moving to teletherapy. And we were all basically able to do it within weeks after the shutdown. And then there's a number of really exciting approaches in terms of innovations on the biology component. Everything from very large scale genetics with many hundreds of thousands of people who are starting to really understand the biological genetic architecture of schizophrenia, depression, post-traumatic stress disorder, substance abuse, leading to new targets. Transformative discoveries in neuroscience, from circuit tools to single cell RNA tools, and tools that we can really use to translate between model systems and human brain, with a really resurgence of postmortem human biology. And then phenotyping, where again, we've historically used self-report data, which is very limited, and to really using much more digital phenotyping approaches to really get at the underlying nature of behavioral biology, to be able to model that better and really understand the targeted therapies better. So a lot of that is moving along with computational psychiatry and large-scale bioinformatics, which is allowing us to take these enormous data sets and pull them all together. That really leads for great promise in the future of targeted psychiatry.
So, Kirill, I really like the way you kind of classify it as a structural problem, scientific innovation problem, and I will definitely go deeper into it. So, with COVID, what it has shown the society is we can rise up to a public health challenge, enhance the cooperation. I really want to get ideas on like some of the public-private partnerships in the CNS space, and also scientific ingenuity. Yeah? If you talk about vaccines coming, even the Massachusetts ecosystem contributing towards that. So are there learnings from COVID that we can apply to mental health, which is also a huge public health issue?
Yeah, I think it's a great question, and absolutely. I think one example is, one of the great gaps that was left was large pharma, and in many ways small pharma and biotech largely left psychiatry and CNS disorders, except for perhaps dementia, but certainly psychiatric disorders, along with their R&D pipelines in the first decade of the 2000s. Part of that was the Great Recession. Part of that was the new opportunities in targeted biology and oncology and other areas of medicine, so that there was both decreased reimbursements in psychiatry, decreased opportunities seen there, and more opportunities elsewhere in a limited amount of range of funds. But I think we're really at the point now that we can leverage the new innovations and possibilities through, for example, government, industry, academic collaborations for everything from access to expand teletherapy, finding ways to enhance and licensure broadly, to enhance new sorts of digital tools, whether that be for diagnosis or for intervention or for AI coaching or other things, as well as a whole new way that we could combine academic research pipelines with industry pipelines to really lead to new targeted therapeutics.
Yeah. So, Kerry, I want to just a little bit go deep dive into what exactly you just said. I started my career in a CNS group way back in 90s, and the complexity, as you pointed out, is a challenge. And you also mentioned many pharma companies have kind of moved away from CNS research. And within this ecosystem, if you look into the investment, I think for neuroscience, they get like 10% of the investment. It's a really small, it's not proportional to the unmet medical need. So, what do you have to say to the people in this call and the investment community that the science is ripe? It's a time for them to come back.
Yeah, I think that's a great, terrific point that if you take depression, I think, is the leading cause of disability. And if you take, the variety of the mental health disorders and substance abuse, they're the primary causes of morbidity nationally and internationally. And yet the amount of money that goes into at both the NIH level, though there's been quite a bit, but particularly at the pharma and R&D level is very much of a gap. And I think what I think a lot of pharma has yet to appreciate is that I do think the time is very ripe. I think we're at in neurosciences now where cancer was right at its inflection point. Where the neuroscience of behavior in 2021 is really unrecognizable from even a decade ago, with enormous transformative discoveries, even in the last few years, from circuit tools like optogenetics and chemogenetics, where we can really dissect the specific functional circuits of neurons from one brain region to another and how they relate to not just behavior, but intermediate phenotypes, physiology, quantitative targets. As well as single cell sequencing that we can do across species, so that we really are making sure if we're studying a microcircuit in a mouse model, we're studying the same cells, the same targets in the same microcircuit for the same intermediate physiology and behavior in an animal system as we are in human. So a lot of ability now to do quantitative intermediate phenotyping, quantitative target engagement, and cross-species validation of biological pathways, really for extensive de-risking of therapeutics. I think another thing to recognize is that while mental health is relatively late to the game of some of the new tools, we're able to integrate all of the new precision medicine approaches of oncology and rare diseases, from large-scale genetics to precision medicine approaches in terms of really understanding target engagement. So that I think there really is a very optimistic hope for novel pipelines that could lead to treatment and prevention and cures.
Yeah. So I like the way you said like a precision psychiatry, because when a cancer patient walks in most cancers, there are mutations, there's a opportunity to have a precision medicine, whereas, as you eloquently said, maybe it's time now for psychiatric diseases. So can you talk about like McLean being a global leader in mental health, and I say that in a way that not only from a patient care, it's almost you have the continuum from a bedside with research all the way till the bedside. Can you talk about like the role you are doing as a chief scientific officer at McLean to promote this, getting from here to the point of precision psychiatry or precision CNS disease therapeutics?
Absolutely. And so I think there's several different ways to do that. I think the first is recognizing again that in many ways, when we back up, that the current noseology that we use for psychiatric disorders is quite limited. And I think when one goes to the doctor, the psychiatrist today, and talks about one's symptoms, you can tell it may in some ways not be that different than going to a doctor with a cough 100 years ago. They could listen with a stethoscope. They could tell you a story about when it started and where maybe in the lungs it was, and you could have a whole story around it. But at the end of the day, you got codeine and you suppressed the cough and you were better. And of course, now we have 1,000 different ways from for specific types of lung cancer to heart failure to specific types of pulmonary disorders and asthma, et cetera, et cetera, et cetera. they all end up in a cough. They all are suppressed with codeine. I think many of our current drugs, the SSRIs, the monoaminergic drugs, are kind of the codeine for the brain. They're suppressing general symptomatology. But we're now getting to the point that we can really uncover the biological pathology differences between 50 different types of depression based on brain circuits, based on postmortem biology, based on genetic, epigenetic, transcriptomic approaches, and really to start, as we understand more, the intermediate phenotypes of what makes up depression, reward processing, threat processing, approach avoidance, how those are conserved across species, so that I think we'll really, the psychiatry we'll be treating in the next decade will look very different than the one we've been for the last decade and really the last 50 or 60 years, I think. And I think at McLean, what we're doing is we really have one of the world's critical masses of basic science to clinical science, from molecular discovery through cell type molecular approaches, through circuit-based approaches across species, through humans, neuroimaging, healthy humans, and large population databases for which we can really understand from cell to community, or pipeline-based approaches to how do we bring this together. And I think McLean and other places within the MGB system and broadly within psychiatry have decades of continuous work in understanding the research pipelines to lead to new targets. And I think those will be fantastic ways for collaborations with industry to jump to the next step.
Kerry, very inspiring. Let me kind of pivot from scientific into structural access. You mentioned about mental health counseling going virtual, and also like 100,000 visits at McLean during the COVID time. So has this been effective? And also, do you see this as a path forward to increase access to patients?
Absolutely. So again, one of the big gaps is people having close access to treatment providers, which in many parts of the country is not the case. And while the transition to virtual in the spring for much of psychiatry, and certainly at McLean for our outpatient and partial programs, was very rapid, it's now essentially old hat, and in some places it's hard to imagine going back. While certainly some things are not the same as in person, many people prefer being virtual. The attendance rate is higher to sessions. The consistency of treatment is also often improved. Also, we think the tools will get better. All of this was built very rapidly on things like Zoom and WebEx and Teams that we already had for conferences. But as new tools begin to be developed specifically for therapeutic approaches, one could imagine integration of everything from sort of AI-based coaching on your phone to a similar tool that can allow you to work with your therapist in a way that the therapist might both be able to talk with you, but also to get some of your passive or active data, or understand how you're feeling in sort of real-time data collection in ways that the therapist in some ways could be much more well-equipped to understand how you're doing than simply waiting and seeing you once a week and hearing whatever you remember from the last week in a 30 or 40-minute session.
Okay, Kerry, very interesting. And in the beginning, I mentioned that kind of like half the people having the issue actually go for treatment. And you nicely talked about the access, and there is also a stigma associated with mental health. How do we educate people on the various mental health issues worldwide, and indirectly that translating into increased access?
Yeah, so certainly as scientists, as physicians, and I think as communities who support mental health treatment and understanding, we've got more to do. But that said, there are a lot of ways we can approach it. McLean certainly sees decreasing stigma and providing education to the public as central to its broader mission of treatment and intervention and research. We do it through a number of ways, through large-scale public awareness campaigns. We have a fantastic program led by Adriana Bobbingchuk and Scott Rausch at McLean called Deconstructing Stigma, and I'll share that website at the end, with stories of famous people as well as everyday people intermixed about their struggles, their resilience, and really to help us understand the commonality of mental health and also the hope that can be inspired by understanding these disorders. We also are sponsored by the Ride for Mental Health, which aspires to be the next mass challenge focused on mental health support, public walks, supporting public figures who've been open about their experiences, et cetera. We also make a whole host of webinars and other educational opportunities free and open to the public, and I'll share some of those as well. But I do think from a research perspective that the real answer to stigma is science and progress in our understanding. We saw as much stigma with early cancer in the 60s and 70s, with HIV and AIDS in the 80s and 90s. And all of this stigma essentially melted away as scientific understanding led to explanations, treatments, and cures. And I think we're going in the same direction in psychiatry.
Kerry, great examples offering hope. So, I mean, we talked a lot about therapeutics, and I want to find out how do you see that digital devices play a important role in mental health?
Right. And so digital devices are transforming the field in multiple ways in which they already are today and ways in which we foresee them changing it in the upcoming years. So today we're already using them, of course, for teletherapy, using Zoom, as well as many other approaches. Remote coaching is a number of programs I'm sure people have seen on advertised, et cetera, for sort of coaching in real time and mental health support and real-time assessment of symptoms. But where we really are excited is where we're going in the future. And that's using things like active and passive data collection from phones, everything from active data, questionnaires coming up, intermittently in real time, in real life about how you're feeling. Again, with if you're not feeling well, then activating a set of, cognitive behavior therapy, AI-based approaches for coaching, but also passive data, everything from social media usage or texting and other components where there might be much more data for how someone is behaving relative to their baseline or feeling relative to their baseline, whether they're depressed or manic or not thinking clearly or have had a substance abuse relapse, et cetera, et cetera. Other components beyond using all the wearable devices and tools that are allowing further data collection and data integration and information feedback for both the patient and the therapist are how we can better understand the digital approaches to understanding the complex phenotypes of psychiatry. So things like EEG that historically is used for seizures, we're using a lot in psychiatry now to understand brain activity in real time. How that can be used also for biofeedback. We're doing some studies now where you can specifically have an EEG trained to a part of the brain called the amygdala, which hyper responds in threat, we know is overactive in PTSD, for biofeedback for how one can downregulate the amygdala using like a simple phone or iTablet based game with a simple EEG device is one very simple example. Artificial intelligence bots for augmenting therapy, skills coaching, behavioral management, and again, digital phenotyping with everything from audiometrics, auditory, visual, facial expression, physical activity, sleeping activity, combined with genetics and biomarkers to really create sort of the biomarker matrices of the future for understanding psychiatric disorders.
Yeah. So, Kerry, very insightful, and we got some questions from the audience. Let me just start with the first one. Even if we increase access via telehealth to remote and underserved populations, isn't it often still unaffordable for many to access mental health services?
Yes, it is. And so I think there's two solutions that both probably have to be enacted. One, I think we have to do better in recognizing we really have to take the parity movement all the way to having insurance and government support recognize treatment for psychiatric issue on the same level that it does for other medical components, because it's really reimbursed at a very different level. That's one. Two, I do think there's an opportunity in digital phenotyping for really expanding the level of treatment. So with most of the current teletherapies, it's still one-to-one. You may not have to physically be in the same office, but it's still one therapist and one patient at a time, and there's only so many hours in a day. But with some of the AI tools and some of the cognitive-based therapy tools, one could imagine one experienced psychologist overseeing 50 or 100 cases that are all being interacted with and coached via AI, and only then have to directly interact when there is something rises in acuity or there's a problem that's not fitting within the normal spectrum. But we have a lot of the heuristics now that from an AI type approach could be used to really expand level of access. And so I think that's one of the kind of ideas that people have that could really expand access in a much more effective way.
Yeah. Thank you, Kerry. The second one is in terms of digital health. Do you foresee developments in digital health for diagnosis, for example, through digital assisted versions like OHQ9 and GAD7?
Yeah, so the PHQ-9 and GAD7 are two of the standard quantitative assessments for depression symptoms and anxiety symptoms. And certainly those, are available now and are incorporated in some of the digital tools. I think so the answer is yes, sort of. I think if we only do that, we haven't really overcome the first problem that we have, which is our diagnoses aren't that useful for our treatments. And so I think where it's really going to be exciting is as we start getting much more precise diagnoses that really lead to more targeted treatments. The PHQ-9 and the GAD-7 as two examples for depression and anxiety. In fact, the first line treatments for both of those are similar medications, the SSRIs like sertraline and fluoxetine, et cetera. But at a psychotherapy level, there could be very different approaches. Like with depression, there can be activation, CBT-based approaches, and certain forms of cognitive behavior therapy. Whereas with anxiety, it might be more exposure-based approaches and other things. So I do think diagnosis is only as meaningful as you have treatments that are useful to treat the different components of that diagnosis. And I think the digital revolution is going to also be part of sort of the psychiatric noseology revolution, if you will, where we're deconstructing and then reconstructing what kind of tools do we have for what kind of sets of symptoms in a meaningful way.
Yeah. So, Kerry, this is really fascinating. Listening to the insights and the way you articulated both in terms of scientific innovation and also structural problems, I think they need to be addressed both to really not only advance the field, but also enable access to all the patients. So if members of the audience have questions about McLean, what is the best way for people to get additional information?
Sure. So we'll share in just a minute. Maybe MassBio, we can go ahead and share the slides here that has a number of the websites, both the overall website as well as some of the websites I referred to for the links for the Deconstructing Stigma campaign, some of the publicly available webinars and public education. And please feel free to email me as well if you can't find what you need, and I'll happily put you in touch in my emails there as well, kressler@mclean.harvard.edu.
Okay. So MassBio, please, if you can show the slide and leave it there, I think that will be really helpful. So Kerry, I'm really looking forward to the day we have the precision psychiatry in terms of the treatment and also all the things we talked about. Of course, we are in the Massachusetts ecosystem. This is something available globally to all the citizens of the world. So that's all the time we have today. I want to thank all of you for tuning into the very important discussion. What I call long-term effects of COVID, even after it's gone, hopefully it's soon. And also special thank you to Dr. Kerry Ressler for today, both sharing his insights and where he envisions the field is going. And also, Kerry, I want to thank again all the work the people at McLean doing to help the patients in the trying times. And I also want to thank MassBio for making this town hall possible and MassBio's mission to improve patient lives. So be sure to visit massbio.org for all our upcoming events. Have a great day. Thanks again. Bye.
Thanks so much, Chandra. Thank you, MassBio.